Good morning, everybody, and glad you're here. Um, and I should just give you a little bit of background on the situation first. Michael is the only original member of this group. It's gone through quite an evolution of people for various reasons. Some of them fairly sad of not being able to be on this panel this morning. So I just wanted to let you know that stuff. So I appreciate Neil stepping in, and actually all of us kind of stepping in to get this going. So I think to begin with then, we'll just have everybody introduce themselves, and then I'll make a few remarks, and then we'll get into the actual panel discussion a little bit more. So I'm Mario Berlingieri. I'm the chairman of the Department of Psychiatry and Psychology at Contra Costa Health System. And Contra Costa County is a county north of Oakland and Berkeley and so on. It's a fairly large health system there. And I'm part of the leadership of that health system. And that's, I think, all I will say about myself right now.
Thanks, Maria. Good morning, everyone. My name is Neil Grunberg. I'm a professor at the Uniformed Services School of Medicine in the United States. I am a medical psychologist and behavioral neuroscientist. I'm a professor of military and emergency medicine, medical and clinical psychology, neuroscience, as well as graduate nursing. And I'm director of research and development for our Leadership Education Development Program, where we train medical students to become physicians for the U.S. Army, Navy, Air Force Public Health Service. We also train scientists and others and conduct research on leadership in healthcare systems.
Good morning. I'm Suzanna Fitzpatrick. I am a nurse practitioner at University of Maryland in Baltimore, the largest hospital in Maryland, where I've been there for 15 years. I've also been a paramedic for 22 years, so I've had a little different perspectives of healthcare. Will be done with my doctorate in May, which is exciting. I'm interested in teamwork and leadership, and especially in healthcare of the transition from expert to suddenly a novice intern, a novice nurse practitioner, and now you're suddenly a leader with no training. So I'm interested to communicate with my colleagues here.
Good morning. My name is Michael Seelman. I'm a leadership coach and executive coach, and I also think of myself as a pracademic. I'm a leadership practitioner and also an academic. I'm a doctoral student in organizational leadership at University of Maryland Eastern Shore. And I also have the pleasure of joining Neil as part of his faculty as an instructor, the leadership program at the Uniformed Services University. Though all the views that I express here are my own and do not necessarily represent any other organization that I am part of now or have ever been a part of. And some of those organizations I've been a part of in the past, I served 19 years in the United States government, working at the White House, the Department of Justice, the FBI, Department of Homeland Security, and you might know the name Bob Mueller, who is recently serving as special counsel. So I was his chief of internal communications at the FBI, and so I coached leaders there on their communications, and my team and I helped execute those communications. So that's what I'll be talking about some, is about coaching executives, in this case in the healthcare context, and I've had the opportunity to coach over 100 leaders on 5 continents. And then another part of the program I'll also be talking about psychological safety, and I'm in the first cohort of psychological safety team coaches, certified, if you're familiar with Amy Edmondson's work at Harvard, certified by her organization to do that. Thank you.
So to put a little bit of a frame around this, and Susanna kind of actually hinted at it, and as so my education in medicine began about 50 years ago, and at that time, all the leaders in healthcare were mostly physicians and providers and were leaders simply by virtue of the fact that they had more technical training than anybody else. And nobody even talked about, even thought about, I think, any kind of training in leadership. That was probably never a good model or a good plan, because if you look at healthcare over the same period of time in America, mostly I'm talking about in the United States, I'm mostly talking about the United States here, it's been declining. There are these evaluations, I think, that the UN puts out every year about the health of a nation. And I think when they first started, the United States was around 11th. And the last time I checked was somewhere in the, like 27, 29. And so we keep on having worse healthcare and health outcomes in our country. So more recently, and you probably know about this more, Neil, it's being attributed to lack of leadership, in part anyway. It's a lot of factors. So, I mean, it has produced such things as 100,000 deaths per year and 1.5 million injuries per year because of medication errors and other mishaps that are completely avoidable. And if that hasn't decreased the quality of life enough and cost enough in terms of health, the actual costs, monetary costs, have risen to where now in America it costs twice as much as any other country in the world to provide health care to our people. So that's one issue. The other is that healthcare is becoming increasingly complex. And if we're going to address ill health and creating well-being, we have to come up with different models. Only about 5 to 10% of healthcare is actually provided and occurs between doctors and providers and patients. And our notions of what needs to be done for healthcare are moving more and more to the street, into the community, and beginning to look at issues such as financial, housing, food, transportation, communication, insecurities, and educational and social justice inequities, and the role that they play in ill health. In addition to all that, there's on the very near horizon, the introduction of an expanding electronic medical record that will integrate with other databases that are being developed. There's the introduction of artificial intelligence and augmented reality and genetic therapies and genome-directed therapies. So it's getting increasingly complex. And also on the horizon is the health concerns and problems being generated by climate change and migration and the intersection of those two things. So with that degree of complexity in the broad domains that need to be addressed in healthcare, if we're going to really address these issues, we need leaders who can learn how to collaborate and coordinate and connect all these various kind of issues. So it's getting to be pretty evident that the kind of leaders that we need to be as trained as thoroughly and as finely honed as the medical providers themselves, otherwise we're going to fall behind. So that's just kind of the context we're in today. So as Michael already mentioned, this needs to be an ongoing thing, beginning with just developing leadership skills, and then team training, experiential training, moving on to ongoing coaching, just like we have ongoing continuing medical education that we have to have. And it has to be done in a context of having a safe culture in which that can take place. So I think that's all I'll say, and I'll let these three continue with that discussion.
Well, thank you, Mario, for those comments. Before I give my own views on this, like Michael, I just need to state for the record that these are my views and are not meant to represent those of the United States government or the Department of Defense or the Uniformed Services University. So now, with that in context, let's think about medicine broadly. I'm going to focus on physicians, but also then to the broader healthcare community is how we think. And for those of you who are familiar with medical education, particularly in the United States and Western Europe and the like, things changed remarkably about 100 years ago with what was called the Flexner Report. And basically, it went from the apprentice system of training physicians and healthcare providers to a science-based model with a set curriculum. Now, I mentioned that because that was a remarkable revolutionary change. That ended up having a great impact, and then things changed again later in the 20th century, but really from the mid-20th century in the second half, the image of the individual physician, usually being a white male physician who would make house calls, who would come to you and was all-knowing, was really the image. But already with Mario listing these and many things we're familiar with, medicine changed in so many terrific ways. Recently, with the turn of the 21st century, there was a new, or some people have called it Flexner II, and there was a change in what was required in medical education, at least in medical schools, and that was a movement more towards what some people refer to as the soft skills, but the importance of communication, relationship building, et cetera. But that's exploded even more, so now I'll bring you up to date. So in general, we see this, and there's lots of discussions, but our own experience at USU, Uniformed Services, because we're dealing with military medicine, just to give you an idea of the size, we're responsible for 9.7 million patients, just the one organization. Then we hand that off to another roughly 10 million patients who will become part of the Veterans Administration Hospital. So 10 million patients in the system. To add more complexity to it in terms of what we're dealing with prevention, wellness, readiness, and enhancing physical, psychological, and some would say motivational or spiritual health to prepare for warfare and stress and difficulty, and then caring for individuals from point of injury through en route care and transport to emergency medicine, but then of course, as we've all learned, not only the physical signs of war, the invisible signs of everything from hypertension to PTSD, traumatic injury, brain injury, et cetera. And there's always been a notion in military medicine in the US that we have both an opportunity to develop procedures and practices to then share with the world as part of soft power and humanitarian efforts, as well as this giant population of patients where we can develop new strategies. So to bring that forward, although at USUS we were founded in the 1970s, notions of different aspects of leadership were mentioned, but it was just slogans, comments. But after Iraq and Afghanistan, a lot of things became clear. The idea that we could actually transport people from point of injury through Landstuhl, Germany to Bethesda, Maryland in less than 48 hours or 24. The idea that the golden hour, we could either in direct contact or through telemedicine from the United States to the Middle East, be dealing with patients. And most importantly, now the topic we're talking about, 21st century healthcare is a team sport. We push this all the time. So at USUS, and then we've been able to deal with medical schools all over the country, the importance of leadership in the development of the healthcare professional is vital. It's one of the reasons many of us have gotten more involved with ILA and are excited about a healthcare community or theme. When searching for the approach, we've studied various models. We actually take and incorporate two different approaches that may be very familiar to ILA. We like Richard Hackman's, the late Richard Hackman's approach towards team building with his 5 different aspects. The idea of having a true or a real team, having compelling direction, goal or model, having an enabling structure, how one formulates and understands authority matrices, having contextual support, and then moving to coaching for feedback, which fits in well. In addition, like many here, and I will proudly say I've learned this from meeting many people here at ILA, the work of Dr. Sorensen, the work of Dr. Kellerman, the work of Dr. Chaliff. We've been very impressed with the importance of incorporating followership. So what we've done now, and what we're advocating and spreading in the United States, at least at medical schools, is that to understand team building means to understand meaningful followership and different types of followership. Whether we use various models, we happen to like Kellerman's model, we've built on it further from her 5 types of isolate, bystander, participant, activist, diehard. We've added a second dimension, aligned or not aligned with the team leader and the mission. And we've added a third dimension, adaptation, pulling from Heifetz and others. Does one adapt appropriately? So the ideas that we're trying to push in the US, and we're hoping globally, learn more about teams, followers, and then something else as I hand this over to Suzanna. When I said it's a team sport, no individual physician can do it all. She or he, I'm happy I can say that now, she or he has all different specialties, but must work with all different types of specialty nurses, psychologists, physical therapists, occupational therapists, emergency medicine folks, and then all the different technical as well as with clergy, and then the rest of the team, the patient and the patient's significant others. That's how we see the medical team, and we really believe that medicine should move to a point where we start to incorporate, have best practices, competencies, and only by partnerships between organizations such as ILA and medical training will we move it forward. The other partner, and I know Michael will speak to this, that Mr. Seelman has brought to our attention, is the rising partnership with the other member of the team, artificial intelligence. And with the rise of artificial intelligence, the human characteristics of the physician, the nurse, et cetera, becomes more important. But I'll turn this over, Suzanne, for you.
So if you were a patient in the 50s or even 60s and 70s, you came into the hospital and you had a bedside nurse who took care of you and gave you medicine and, maybe brought you food, did a little bit of an assessment on you, took care of you, was with you most of the day, and that nurse would see usually a white male as the doctor, either once a day, if it was Monday through Friday, no doctor Saturday or Sunday. Sometimes if you're in a rural hospital, no doctor Monday through Friday, just maybe once a week, who would dictate orders to the nurse, no questions asked, just do it. So as we've evolved, and as Mario mentioned about our rising healthcare costs, our more impact on patient safety, our poorer outcomes, and errors that we're making, we all as a community had to think about, is this the right way? And as a nurse practitioner, I would say no. So even as I started healthcare 20 years ago, as a paramedic bringing patients to the ED, where I was the first person to see the patient in their household, laying on the street, wherever they were, my point of view was not counted. I would give report to the nurse, who would write it down, who would then report to the doctor. And there was no collaboration or interaction between the 3 of us who were all equally vested in the patient of what to do. So as I moved into the emergency room as a nurse, that sort of evolved even further, and I work at a teaching hospital where there's a variety of different people at different stages of their academic training, physicians who are in their residency, nurses who are students, physical therapists who are students, as well as attendings of various levels. And we decided that this was going to be a different way. So hospitals and medical facilities throughout the country began looking at more patient-focused care as opposed to physician-focused care. And as the baby boomers physicians are retiring, there's not enough of them. So who is going to come fill that gap nurse practitioners, physician assistants, but also physical therapists, social workers, mental health providers can oftentimes fill the void that the physician was providing. As Mario can attest to, you don't necessarily need to see a psychiatrist if you're having a substance abuse issue. You don't necessarily need to see a doctor if you're having your finger splinted. There's lots of parts of healthcare that have nothing to do with a doctor or a nurse practitioner or a physician assistant. Maybe you need a nutritionist, maybe you need physical therapy. And thinking about those people are just as significant in the patient care. So now when I come to work, we have multidisciplinary rounds every day with the bedside nurse, the physical therapist, the occupational therapist, the social worker, the case manager, the nurse manager, a nurse practitioner, and a surgeon. And we all talk about the patients together, sort of communally, because we talk a lot of medical jargon. And then we all go into the patient's room. We talk to the patient as a group. And at the end of the day, after we're finished with our talking to the patient, we say, what questions do you ask or do you have? How can we help you to make sure we're not missing anything? This is the most critical of times for patients, and we are making errors. So what can we do? Not only hear our voices, but hear the patients and their family members. And I always ask the patient, as do many of my colleagues, if their patient is by themselves, would you like me to call somebody and put them on speaker while we're talking? So that there's another voice, hearing the words, having the conversation. So as we're evolving to a more teamwork model, we don't really know what to do with that teamwork. So yes, we have lots of people at the table, but not everybody at the table knows what to do with their voice. So how can we teach the physical therapists, teach the social workers, teach the new training doctors, teach the nurse practitioners, teach the nurses that their voice is just as important as ours, but also we need to hear everybody's voice. So the thing that we're interested in is how to provide a level of teamwork to these people who have an extremely high level of knowledge about their point of view from a medical standpoint, but they don't really know how to interact with each other and hear each other's voices. And I would say that people are in healthcare are pretty good in an emergency to understand and say, you do this, you do this, you do this. But when we step out of the room and have a conversation, we're not so great about listening to each other.
Thank you. If I can build on what my colleagues were saying, is that you heard it from them, the evolution of healthcare and leadership in healthcare and how that's changed over time. And now you have this multidisciplinary model that Suzanna was talking about. And for the new doctors coming up, thanks to Neil and his colleagues' works in other medical schools across the country, and now we're working on doing it internationally, there'll be more leadership training for doctors going through the training now. So be prepared for the environment that Suzanna, Mario, and Neil talked about. But what about the ones that are already in leadership positions? Like Mario and I were having a discussion the other day, like he's the head of a department. And I said, if I was a new head of a department, what would you suggest to me in terms of leadership training? How might I do that? And so we had that conversation, and sometimes there's in-service training, right? We talked about training as you're going through your formal training as you become a physician or a different type of healthcare provider. But the people that are in these authority or leadership positions now, how do they cope with this change in medicine? As Mario eloquently talked about how all the different aspects that are expected to them to lead now, how do they do that? So in-service training can be part of that. And you heard about the evolution of this panel. One of the people we originally had on the panel, Rob Followell, he's on the program. He's been the CEO of a hospital. And one thing he noticed is that there wasn't this type of training. So with his Followell Leadership Series, he trains healthcare teams as teams in their position. And then they have assignments in between the leadership training sessions so they can have that experiential learning and put it into practice and have some reflection. So there's different ways, and you'll hear us talk about kind of this professional development and different modalities throughout the life cycle of a healthcare leader. From the earliest stages of, Neil's teams have even talked about into admissions. How do you encourage people to have those skill sets as they come in to the training systems? And then how do you have that self-reflection as they go through training? And then as they're in these positions, as healthcare providers, as leaders of healthcare systems, how do they continue to develop their leadership? So that's one of the things that we want to talk about. It's not just at the beginning, it's all throughout your history as a healthcare leader.
I'd like to build on what Michael's opened up. You think about it, there's this almost interesting irony. As I mentioned 100 years ago, we realized that medicine should be more science-based. But every one of us has a computer in our pocket, accessible, that is so much more powerful than anything we imagine. Partner with AI. The irony, of course, is with that tremendous amount of information quickly available, communication skills become even more important. So as Michael said, and we also agree, that although our team had focused on what's called undergraduate medical education in the United States, that's actually, an MD is actually not a graduate degree because in many countries, a bachelor's degree is not required. In the US it is. But really the progression, the life cycle Michael spoke to is so essential. How do we all think of healthcare, as well as not just we healthcare professionals, but the entire society, the focus on wellness and well-being, and what do we do for prevention and the like. Then how do we now start selecting healthcare professionals? And one of the movements we're seeing now is exactly what Michael said. Should admission process go well beyond the MCATs and GPAs and actually test not just experience, but how would one respond, not just as a leader, but as a team member, or more broadly as, once a dirty word, we embrace the word, a follower. A follower because a follower needs to be a powerful teammate. Whether one does this with different experiential learning or tasks in the interviews, people have even talked about adding escape rooms and the like to the admissions process. How funny it is, and you think about those issues. But then it depends on what elements, because something else we need to embrace is the search for a common language, certainly in healthcare. What we've done is we've searched all of these different models, as well as not just leadership from the academic and scholarly and business worlds, but from military. Because we sit at that nexus between military and medicine, we're up to date and we work a lot with West Point, Annapolis Air Force Academy, Coast Guard Academy, institutions that focus entirely on leadership. But again, they've moved from the authoritarianism of decades ago to more team-based and human and machine. So we've argued that these elements can be taught through a life cycle into, again, the area Michael's suggesting. What we're finding that's so interesting is certain competencies are easily identified and understood in knowledge base. But perhaps the greatest challenge we're seeing so far with millennials and perhaps Gen Zs is communication being sending, of course, but receiving, verbally and non-verbally, as well as the importance of contextual change. But we use context in the broadest sense. Physical, it's night, day, it's hot, cold, etc. For us, it's sea and the air and the jungle and the desert. But the physical, there's other aspects of physical context, and that is within ourselves. Are we hungry? Are we tired? Are we exhausted? Are we nourished? Are we not? And then psychosocial context, following for Kurt Lewin's notion of a broader environmental way, as well as cultural sensitivity. So we're adding all of these pieces, but of all these, I'll be interested in other people's experience. The one place we're finding today's medical students having most difficulty is peer evaluation, peer feedback. Partially, we've seen, at least in the US, a cultural shift. We have a generation of people who were, one, as we've kidded about, participation trophies, but can one give honest feedback and understand that to critique another colleague is to show them respect. So we'll be curious, I'm particularly interested in everyone else's views, and Michael, obviously you're an expert in coaching, is how do we get people to understand that self-reflection and understanding of not only who I am, but how others perceive me and respond to me. How do I comfortably give feedback to others? And how do I accept that I need to continually grow rather than reflect and have regrets for how I've been? So I'm very curious of my colleagues' comments on that.
So we're all in the age of computers and phones, which are so great. And it's so much easier when somebody makes a mistake to send them an email, or send their boss an email. It just feels good. And then it's like, woof, I'm done with that. So we, where I work, have this system that if there's an error or a mistake that either affects a patient or has hurt our feelings, we can just put it on this anonymous thing. It goes to their manager, and they don't know who it is. And we've really, that has been the wave of the future at our hospital. It's not great. So when I precept people, when I'm talking to people at my unit, when I go instruct at the nursing school, I always tell them at the end of the day, let's have a quick debrief. What are some pluses and minuses? What are great things that you did for the day? What are things that we can improve on? Because we as people typically know when we've made an error or something that goes, something about that didn't feel right. And especially in healthcare, I sort of call it the spidey sense. You're like, something feels funny about this. I don't know what that is, but something feels funny. And we know those feelings as human beings. And it's really important at the end of the day, at the end of an incident, at the end of sending somebody to the ICU, at the end of doing CPR, have a little time of self-reflection and also give that time for feedback. And I have found that it's much better, I'm sure all of you have, to have a conversation in person. And typically, learning how to give negative feedback, but constructive negative feedback, is helpful to everybody. And almost all the time, the other person will be able to provide that feedback for you, and then it's a little bit easier to have the conversation. But having those crucial conversations, having that ability to grow, and only improves the patient care. And at the end of the day, if our mindset is about the patient, we have to sort of let go of the feelings about it. But it has been very difficult. And I think especially in this millennial type era where that is our new set of providers, that they're so heavily focused on electronics and that sort of communication, and they don't know how to give negative feedback. They don't know how to give positive feedback. They know how to send an email. So putting the phones down, putting the computers down, and having a conversation, I think, is critical for any stage of care that you're giving in healthcare, but also in a professional standpoint at the end of the day. How did it go? Anything you want to work on? I mean, I do it with my 6-year-old. What was the best thing about your day? What was the thing that we can improve upon? And having those conversations, I think, is so critical and will only help the patient at the end.
I know from my own personal experience, what it takes is initially doing that self-reflection, getting to know yourself. Fortunately, I mean, I'm coming from a psychiatric point of view, and in my training, during my training, I began a therapy. And once you learn how to, look at the sides of yourself that seem to be a little bit more uncomfortable, and you begin to have compassion and empathy for yourself, then it's so much easier to do that with other people and talk with people in a way that can help them. So one of the things that we've been doing in our system is we've been trying to get everyone trauma-informed trained in our entire system, from the janitor all the way up through the CEO. And that's one of the first things we teach is empathy and compassion for our colleagues. And it eases, kind of lubricates that kind of conversation that you have with each other. And that's an important thing.
So what you hear us doing is we're in our conversation, we're blending different modalities of professional development so that people can lead effectively in this multidisciplinary team-based environment. And for a lot of healthcare systems, this is an evolution from a more hierarchical model to a more horizontal, flat model. And so the system that Suzanna was talking about in her hospital, I think that's great. It may be that the hospital's not there yet in, as Heifetz would call it, protecting the voices from below. In the traditional hierarchical model, maybe there's some doctors possibly at the hospital that may not take someone pointing out a medical error well, right? And it's good that those things come up and so that those mistakes aren't repeated. So I see it kind of as an evolution, and I'm glad, Suzanne, you're trying to move you and your colleagues, your hospital, to being comfortable to bringing those things up. And I would say, and the physician or the team leader soliciting that input, right? Not just hoping people bring it up, but actually soliciting that input. And that's what I do a lot in coaching. So we've talked about training, and now I'm trying to transfer a little bit into coaching. And so when I work with these executives, that's what I do. I try to teach them how to encourage and solicit feedback on their performance as an individual and on their team's performance. And we do that using some data. We use 360 assessments, where their direct reports, their peers, their authorizing environment, give them feedback. And what I try to do is work with my executive clients or any type of leader on having this learning and growth mindset. I think feedback is a gift, right? You just start with that. A lot of my clients are also in private corporations, and how many times have you gone to a hardware store like a Home Depot and they say, hey, if you fill out this survey, you'll have a chance to win $1,000, or we'll give you a Starbucks gift card, right? It's because feedback is a gift, right? And we're trying to get people to take the time to evaluate our performance. It's a gift and should be treated as such. And that's what I try to encourage the leaders to think about, that feedback, and that's something they should solicit. And there's more and less skillful ways to solicit feedback, and there's more and less skillful ways to respond to feedback, right? And there's also more or less skillful ways to provide feedback. And that's the things that I talk with these leaders about. So often I'll start with, hey, leader, when you're soliciting feedback, you might want to train your team how to give you feedback so you'll be less likely to be defensive. And one way to do that is to say, hey, boss, I'd like to see more of this and less of that, right? In the future, future focused. So Marshall Goldsmith, I'm trained in his methodology, stakeholder-centered coaching. He calls it feed forward, not feedback. Because the past we can't change. So if someone on my team says, hey, doctor, I'm leaving the hospital now, but for the past 5 years, you've never welcomed my input. I can't change that now. I'm like, okay, I screwed up for 5 years. I feel terrible, right? So that would be feedback. Not much you can do about it. So we feel just judged as human beings because there's nothing we can change. But if that same nurse or physical therapist or social worker comes to me and say, hey, doctor, when we do the rounds, you seem to just give your opinion and don't really ask other people's for theirs. Or you might say you do, but you don't pause, and so no voices come in. Oh, I didn't realize that. So in the future, maybe we could pause a little bit in the next meeting, the next time we do rounds tomorrow. Can we try that out? Yeah, something I can do something about in the future. Easier for me to accept and to act on. So that's the kind of thing that I talk with my clients about. And at 360 feedback, we can also see how they are doing in these different dimensions. And it's data-based, right? Some people might think, oh, I'm doing great. You know, at dinner last night, we were, in a group of us were talking about how someone in a group said, hey, how do we do as a group? I think we got A minus, right? Don't you think? Is that right? Is that how we're doing? You know, that's not really bringing in data, bringing other voices. People might not feel like they're really being solicited there. So the 360 we use kind of as a baseline, and then we come back after I work with them as a coach, and we try these behaviors of feedback, putting the feedback into action, where the leader agrees with the feedback, and then getting some data again. Have we seen a change? Have your stakeholders seen a change in your leadership behavior? So that's one way to incorporate coaching into creating this environment where these voices can be heard, where the medical errors can be reduced, where the innovation can be encouraged. That's really critical to encourage that.
I just wanted to add to that, especially in healthcare, where we're talking about their patients' lives. It's not whether you're hurting my feelings at the moment. And so, yes, there is a great point to feed forward. I love that concept. There's also a new concept that has emerged in the past 5 or 10 years of a hard stop. And so understanding that during a time of crisis or during a time of patient care, that everybody's voice is equally important at any time, but certainly at that moment to say, Dr. Seelman, I need you to stop. You're not being sterile. Neil, I need you to stop doing this and things like that, and making sure that everybody has the opportunity to stop at a moment that feels unsafe.
There are a couple of concepts come to mind that might be valuable to share with you that we use and seem to be helpful. First, when we talk about a team, what does it mean to people? Many people, at least those students we deal with, think of sports teams and the like, which still might have hierarchical structure. But the metaphor or the analogy that we like to use is a jazz ensemble. And I notice I'm saying a jazz ensemble, not just a musical group, because musical groups, orchestras, bands, et cetera, will have sections playing together. But the notion that every individual in an excellent jazz ensemble has a different voice, different expertise, a different instrument. There's only one of each of us. We play ensemble at times, playing off literally the same sheet of music. But the part that's important is there may be a given leader who pulled it together, created the music. But in jazz, even if an individual wrote what's called the fake book or the lead or the head that goes with the jazz, we then take turns as we improvise. And as Susanna takes a lead because she's improvising, do I now complement that depending on the sounds? Do I go to a soft chord structure? Do I go in harmony? Or do I stop playing entirely? And that's one notion that we're finding very useful. Another notion that we've brought to it, and this is in terms of the development of the individual, is yes, indeed, the individual needs understand different kinds of feedback. Self-awareness and feedback here, I'm completely in line with Mario, my own background in psychology. But unlike Mario, I'm not a therapist, so I'm a scientist of psychology, so I tend to go more towards the relationships between how motivations, cognition, behavior work in these other structures. Because so I move outside the individual, how do others perceive me? Understanding that, we suggest various elements that need to be considered, a conceptual framework that we've used by taking from many models that exist, character, who the person is in every way, competence, what we do both in our role specific, as well as our transcendent leadership competencies, critical thinking, problem solving, decision making, conflict resolution, emotional intelligence, context dimension, and communication, but across 4 psychosocial levels: the personal, the dyadic interpersonal, the team, and the organization. But within that, it's to what end? Now again, we like taking an eclectic approach when at different times, whether it's servant or authentic or transactional, transformational, and this is where we like Ron Heifetz's work of adaptation, but we've taken it what we believe is one step further. We now refer to an allostatic leader rather than adaptive leader. So we've combined Lewinian field theory with allostasis, the theory of allostasis. Allostasis, for those of you who are not familiar, is the idea of responses and changes to stress, the work of McEwen, Sterling, and Iyer. Adaptation is actually a homeostatic process. So it would be analogous to heart rate. Heart rate would respond to a situation, then return to where it is. Adaptation would be blood pressure. It changes, it returns to where it is. Allostasis is like the immune system, in that after being exposed to something, it not only adapts, we adapt, learn, and change so that we're better prepared for the future. Now, it could be that that could get out of hand, and we're starting exploring the idea, could we actually have a feedback loop where it becomes dangerous or deleterious to self, as in autoimmune diseases, which we think moves that way. But I'm suggesting that these concepts and models, and I must say, every time I come to ILA and every time I sit on an airplane talking to someone coming or going for this conference, I learn something new. So it's getting more and more complex. But very seriously, it's this idea of the fact that we are 4 different professionals interested in healthcare with wildly different perspectives, but we are a jazz ensemble. When can we play together? When do we need a new instrument? When do we learn to play in different ways? But these are notions. And the final point that occurred to me now that I wanted to add, something we just stumbled on this year. As we've introduced followership types for our students and our students from beginning to the end of med school, I was surprised to find how valuable that realization was in making them better leaders and better team members in two senses. Do you have a tendency towards a given type of follower? Are you an activist or participant, a diehard, et cetera? And should you adjust? And then if we put the adaptation allostasis to follower type as well, almost light bulbs went off like, oh my gosh. And how do I, as a leader, assess and understand my team's follower types so that I can optimize performance? I don't have an answer, but I'm excited to report that the interest and the enthusiasm of these concepts has raised remarkably with these insights.
I love the jazz metaphor because it includes a lot of things like, so what happens if somebody makes the wrong note? You know, in improv. Right, yeah, that's the whole question. There are no wrong notes.
Exactly.
Because then you just, if you're really into it, you just follow that lead or move forward with it. But, you know, some of these things, and these are wonderful things that we're talking about, but I have a question, and that is, this doesn't just happen overnight. You need to kind of create a certain environment in which this can occur more easily. And so my question is, and then if we have time, I'd really like to open up questions to other people in the audience. How do you create that environment where people feel safe to be able to practice these things? Because it doesn't just happen.
I think, Michael, you would like to speak to psychological safety, I think.
Thank you. So the kind of the C's, like we talked about having training and team training and experiential learning, and we talked about coaching. So Mario is shifting us now into the culture and the climate of the organization. So how do you impact that? And in a healthcare system, it would be great to encourage a culture of learning and psychological safety. And those two are related, right? Having a psychologically safe environment is going to also lead to learning. And so I mentioned in my introduction that opportunity to become a psychological safety team coach. And through that, and Amy Edmondson's work at Harvard, she's done 20 years studying psychological safety, primarily in healthcare organizations. She did a lot of her work in healthcare organizations to prevent like the medical errors that Suzanna talked about, like that. I love that stop and let's think about what's going on right here at this moment. And so she has this instrument called the Psychological Safety Index. And as coaches, I like starting with that baseline data, just in case people think there isn't anything that needs to be improved. It's always good to get that data first and then rise certain issues through that. And often the first time we do it anonymously, right? And so we send out that index, and then people can then say, like, how do I feel about this team? When new ideas are brought up, how are they received by the team? Notice I'm saying not just the leader, right? The leader of the team is important, but there's also other team members that react when a medical error is being pointed out, when a suggestion for an innovation is made. How does the team and the leader respond to those things? And then we send out a survey based on Amy's work that brings that out. And then as coaches, we debrief the data with the team. And we go through it. And we serve as that facilitator, providing a safe container to have those conversations. We don't have to necessarily out, but we say, it looks like one member of this team or a couple of members of this team are not feeling so safe, that they need to use the anonymous system to bring up something that's going wrong, right? And so as a facilitator, as a coach, we try to bring those things out and help the team have that conversation so they can change that climate, that culture within the team. And then as a larger healthcare system, how do you encourage your leaders to do that? Maybe you have them model that it's okay to make mistakes and learn from them. From my experience, when we did a new leadership development initiative at the FBI, to make it serious, the top executives of the FBI sat on a panel in front of the rest of us that were going through the program, and they talked about mistakes they had made in their career and what they learned from it. right? That's their modeling the culture they wanted to see in our organization. Bob Mueller, when I went to the Executive Development Institute at the FBI, he came down to Quantico for a class discussion, and a case study was on a mistake he made. And he came and talked with us about it and what he learned from it. And it was even a case study at Harvard, the business school. You know, he was very good at saying, I made a mistake. He had to go in front of Congress anyway, so he could talk to his own team, you know. But he role modeled that. And so that we wouldn't make that same mistake again as an organization. So it's how do you create that culture? And I'm sure my colleagues will be happy to talk about it. I'll talk more about psychological safety in a moment.
I think it's a really good point that Michael brought out is about making mistakes and owning mistakes. And it's the thing in life that you will always get in less trouble, make a less long-term mistake if you just own it and move on. And Mario and I were talking at dinner last night that in healthcare, you have to make a decision. You can't be stagnant because it's about the patients. It's not about you. So if you're like, I'm not sure, I don't know, you should go talk to a colleague. You should look it up on an appropriate, medical website or use your phone and then make a decision and move forward. And you're gonna make a wrong one. I've made loads of them. And I circle back to my team. Well, guys, the reason I made this mistake was blah, blah, blah. It's never personal. And this is what I'm going to do for the future. Any feedback about that? Does anybody have any insight? And healthcare is really moving forward to stopping a moment. Does anybody have a suggestion? Let's do a 2-minute callback. Let's talk about the things we've done, because that's the stage we're moving forward with healthcare. But really trying to have an understanding of self-reflection of that I will make a mistake, it will be okay, and yes, I will make a mistake on the patient. I mean, that's just the nature of healthcare. There's nothing we can do about it. But how can we facilitate our teamwork and getting other voices heard so that less mistakes are made?
As we deal with this issue, clearly we all make mistakes, and people make mistakes in various situations. The issue in healthcare is the mistakes are existential. I just want that to sink in. It's true for the military. It's true for fire departments, emergency. They're existential. If I make a mistake, this person dies or is permanently disabled. So what happens because of the extreme potential negative outcome? Sadly, many of you may know that although knowledge and skills in medicine increases dramatically, at least linearly, if not exponentially, with increased education and training in medicine, one thing dramatically decreases: empathy. Study after study shows that empathy with other human beings decreases from year 1 through year 4 of medical school and continues to decrease during residency and into practice. Now let's let that sink in. Why? Because it's a powerful coping mechanism. How do I deal with the existential mistakes? Well, it's more about the system. Now I bring this up because I mentioned earlier, and I know we all share, that as human and machine become partners more, and the human elements of relationship and team building and communication, emotional intelligence, social intelligence must be increased. What about this other issue? So here's something that I have not seen enough of. We've started to look at putting this literature with it, and that's various cognitive heuristic biases, the famous work of Kahneman and Tversky and others. But I believe that we need to examine more what are the implicit cognitive heuristic and biases that we do in order to cope with and find psychological safety. So can we create psychological safety in exchange of critique? Can we learn to live with our mistakes without becoming cold? So I'm actually going to ask Mario as our psychiatrist to comment.
Great question, because you're right. I mean, because of the costs, potential costs, and I'm just flooded with memories of all kinds of things that have happened in almost 50 years. But and the loss of empathy. you know, because it is a protective mechanism. Talk about allostatic load. And allostatic load is not the place you ever want to go, if you understand right. So you're protecting yourself from that extreme distress by giving up empathy. And at some point in time, that is important. I mean, I work with trauma patients quite a bit, and you can get so empathically involved with them that it damages you to be that empathically involved with people. So what I have learned over the years and what I teach to the residents is, how do you transition from empathy to compassion? Because that's the move that you make that both continues to serve them, but also protects you from that allostatic damage. And we talk about that a lot, because that's one way to do it. You don't ever give up compassion. Compassion isn't going to burn you out, but empathy will destroy you if you just are empathetic endlessly. And I know other people here, I know, Aman, you've worked a lot with trauma patients, so you're shaking your head, so you must understand the necessity to do that. But that's one thing that comes to my mind.
I mean, you haven't been a healthcare provider if you haven't been crying in your car at the end of a shift. I mean, it's terrible. Yeah, I messed up. I made an error. This is so awful. You're awake all night. I mean, we all do it. And then you just learn to not.
So here's the good news part. How do you lower the chances of those types of mistakes happening? And psychological safety is one of those answers, right? It's not going to prevent every error, but it can reduce the incident of error and also lead to innovation, so that you don't have as much burden, or you reach new outcomes for your patients. So there's 4 domains that Dr. Amy Edmondson talked about in psychological safety. The first is, does the team feel comfortable having open conversations, like Suzanna was talking about, moving from the anonymous email box to talking about it in the moment in a skillful way, right? A skillful way of creating that culture, that environment, so these things can come forward, of presenting things skillfully and receiving them skillfully. And then there's something else we talked about, it touched on, is like a willingness to help, right? Are you committed to the team as a team member, right? Are you willing to help out, to go that extra mile, to use your discretionary effort on behalf of the team and a patient? So another dimension is your attitude toward risk and failure. Now, in the context of psychological safety, we're not necessarily talking about the medical error risk, which we talked about the emotional burden that can have. Here we're talking about interpersonal risk. So if this was my team and Dr. Fitzpatrick was the doctor, and I was bringing it up with her, what's my interpersonal risk? Is she going to take me off the team, or do I think that? I don't know for sure, right? Because maybe I don't bring it up so skillfully, right? Or maybe I bring up something that she's already accounted for. Like, so what's my attitude towards interpersonal risk? And what's my attitude when I strive for something different? What's my attitude as a team member towards failure? And so that's some of the dimensions that we talk about for psychological safety, is also looking at it from those aspects, so that we as a team, we can evolve and be in a healthier place, so we're able to have those conversations, that we put our effort into it, and that we can prevent as best we can those kinds of outcomes, so we can serve our patients the best way possible.
How do you folks feel about, let's opening this up to questions in the audience? Oh, there we go. Yeah.
Hi, Shelley from ILA.
Mari, why don't you just repeat the question? Mari?
Okay, so recently in Silver Spring, pretty much across the street from our office, we had a police officer commit suicide in a very public way. And as you're talking about, Susanna, going into your car and crying at the end of shift, I'm sitting here thinking, what is it that can be offered out there, perhaps through this community, to help others in service positions?
So sadly, actually, I know a lot about that particular case because one of my youngest son's best friends is a police officer and spoke with that particular fellow that morning. So I know a lot of backstory and I know what I can reveal. That's relevant. So sadly, this is a case of a police officer, about 19 years on the force, married, good marriage, 2 young kids. However, had gotten increasingly overweight because he had in previous police exercises and activities gotten hurt, and he actually was living with chronic pain. The chronic pain resulted then, and you can see this cascade of he wasn't able to maintain his fitness as much. He was getting upset about that. He was feeling he couldn't do his job. Literally that morning, everyone thought was fine. When he was taken out, the original assumption was that there was a shooter in the area, so there was a lockdown, because no one even considered. And I mentioned this because identifying suicide prevention is something we do a lot in military medicine, particularly in people who return from warfare, is really important. What can we do, Shelley? Wow, there are several issues that were intertwined there. Issues of wellness and fitness, issues of pain and pain management. We've watched the pendulum swing from opiate crisis to don't even touch any of these drugs. But we get to this issue, I believe, in focusing more broadly on wellness of a community and understanding what could happen. Sadly, the police force involved had not done much before, but they immediately responded, and I knew this directly because I learned it that day. Every single member of the force in the county, including huge number of officers, didn't know them, were required to see a counselor. I spoke to some of the officers. Apparently the counselors were terrific and realized they had to open, and it fits beautifully here, the idea of sharing the information, sharing their fears, their concerns. But this is a serious issue. Very, very sad case. Oh, yes, of course.
But I think that in healthcare, in police, in EMS, we need to get the perspective of something terrible happened at work. Your patient died. You made a big mistake. Somebody you've been really connected with, went to the ICU. Instead of stopping after that moment and saying, "You're doing okay? Need a break? What can I do for you? Need some water? Reset, right? I need you to take this other patient right now," right? That's the culture we have. Police, the same thing. They go to a house where a child is abused. They complete their report, and then they have to go to their next call. There's no stop and reset. Same with EMS. You go on a shooting. You see a house that is deplorable and people are injured. You go on the next call. So I know Mario is so focused on it, but we just have to remember, from an ILA perspective, nobody in my hospital has ever heard of ILA. Why are we not talking about it? Why are we not having these conversations? So when you know a police officer, when you know a person in healthcare, when you know somebody in EMS, be like, there's this really cool organization of support that people care about you. And it's not just about taking care of the patients. You can't take care of the patients if you don't take care of yourself.
Exactly. And I go from house to house. I do house calls. That's what I do. And so, yes, I come out of some houses and I'm devastated by the situation. And fortunately, I usually have to drive to the next place and gives me a little bit of a break time, which I've now come to realize is a very important time. But yeah, it's difficult. It's not easy. We have one question here first, and I'll come back to you, and then to you. Okay.
Thank you. Yeah. Well, first and foremost, thank you all for being here and taking the time. I do appreciate it. Sean Green, University of San Diego. I'm actually, I should say a disclaimer as well. These are my own thoughts and not my wife's comments. But while I'm asking a question on behalf. So my wife is a supervisor of an ER in the United States. And one of the things I overhear a lot we talk a lot about her experience and all that. But one of the things that she's mentioned has kind of become a real challenge these days is we mentioned healthcare costs doubling and all of that, but staffs are shrinking, right? There's a nursing shortage, especially in ERs, right, as an example. So she's dealing with, trying to manage a staff, do the best she can, create a culture with dwindling resources, and which of course impact motivations and all that kind of stuff. I'm just curious, and I know there isn't a cure-all, but I'm just curious of how you've experienced this, how you've, dealt with it or whatnot.
You mind, I'll answer this real quick, because when I went to Contra Costa County, had been designated as a crisis county because of the dwindling healthcare there. I think in one sense, this is, crisis always creates opportunity. And I think at least in our county, this has actually pushed the idea of having to get out into the community more and begin to deal with root causes as a way of having less resources in the traditional areas. I got some of these ideas from, I'm involved in this Harvard program of refugee trauma, and once a year I meet with these people from various places around the world. One of my colleagues who's a physician in Nigeria, he was saying that they have 70 million people in Nigeria, and they have 120 psychiatrists for the whole country. And I said, because we were talking about a shortage, and he said, "Oh, this is what we're dealing with." What do you do? And he's very active, and he says, "What we decided to do, we have gone around to all the churches in the entire country, every single church that they could find, and they began training the clergy and people in the clergy to address and deal with mental health problems." He said, "Because we don't have enough psychiatrists." He said, "We just kind of brought it to the community and say, there's a community, can you help us out?" And so that's one solution, but you guys might have it's a big problem, yeah.
So one thing that's on the horizon, and Neil talked about this, is artificial intelligence. And artificial intelligence is getting incorporated into medicine. So that in addition to kind of working more on prevention and working with other partners in medicine, artificial intelligence, the system, in one definition, I do research, original research on this, it's an intelligent being, right? So you got another team member. We talked about the human team members. You got another team member that the doctor, the other health practitioner can work with and extend kind of gives them superhuman abilities in what they're able to do. You can have intelligent systems that screen for suicide or screen for health problems to mental health or physical health, right? It extends the ability of a doctor. A lot of doctors now are, including my wife who's a psychiatrist, is seeing patients remotely. It saves their time, saves her time, and transportation. You have doctors that are using robots to do surgery in a different physical location than where the doctor is, and they're controlling the robot. So, and that's really important in military medicine, right, where the injured patient is maybe in a forward deployed area, right? These are going to be happening more and more. So there are some technologies that are being used now and more on the horizon to help extend the reach of the doctors as a new type of team partner.
I was just going to add to that because I truly feel your wife's pain of, writing on the triage board a 24-hour wait time to a patient to come back, and there's not enough staff, and there's not enough beds, there's not enough people. What do you do? So typically, people stay at a job because of the money is really good, the schedule is really good, or your team is really awesome. So you can't fix the first two, right? The schedule is 7 to 7. You work 12-hour shifts. You work 36 hours a week. I'm sure as a manager, she works 50 or 100. You can't fix the money, right? The hospital has a certain amount of budget. This is how much I can pay you, things like that. So what can you do about the team? So I think that's the part that she can really dial into. She's like, all right, I am the manager of this team, and I have 25 employees, and each member brings something different. And so I need to find out from each of those members, what do they want to do to improve the team? Because that's the only variable she can fix, right? She can go to the hospital and say, I need more money, I need more beds, but she can't control that. It's impossible, right? She's one person, so she can affect the team. So say, all right, the 5 of you seem really interested in education. So I want you guys to make an educational group, and we're gonna educate our patients about whatever the topic is. All of our patients have terrible substance abuse problems. So let's figure out, let's create some resources for them. People like being engaged, they like feeling valued. Find what drives them. And these people over here seem really interested in going to conferences. And so these are 5 really good conferences that I found that our hospital will pay for, because typically hospitals will have a small budget for continuing education, conferences, or going back to school. And these people over here, you guys all seem really interested in being an NP or going to DNP school or doing something else. So make sure that you're applying to the educational reimbursement, because that's something that's really attractive. My hospital pays the least amount in all of Maryland, but they have the best tuition reimbursement. So for me, that's my attractive part. And then again, in these 5 people, what's the thing that you're really passionate about? Are you really passionate about MASH casualty incidents? Are you really passionate about quality improvement? Let's get you on the committee. Find the thing that will spark them, because that's what she can change. She can't change the other things. So I think you really need to, for her, oh man, dial into the teamwork part, because that's the only thing that she can fix. So I just did an escape room for the ED nurses at Maryland, which was really fun because their teamwork is really bad. And so that was a variable that I could find. I went to quality improvement. I said, I need $700. I'm going to do a escape room for all the senior nurses so they can just spend the day doing teamwork, something that's not clinical. They designated a day that they could do it. It was already budgeted for. We did that, and they all thought it was awesome. And it was just something different. So think about for her, what can she dial into from a teamwork perspective, and she might need to spend 2 days in meeting every single senior nurse and saying, what's your passion? What's your drive? What's your why to being here? I can't fix your schedule. I can't fix your money, but I can help you think about what is your 5-year plan. That would be my suggestion for her.
I just want to add one more thing that was similar to the Nigerian story, and that is in our county, Kaiser has a very big presence, and one of the psychiatrists there who was also interested in trauma developed this program with a social worker. After they would do therapy with people for a while, then they put them in groups, and then they would have people from the groups start a support group completely run by the patients in the community that they would meet. And Kaiser would provide the space, but there were no therapists, there were no doctors, or no nurses, just the patients getting together, ongoing. And so we've taken that model. We haven't gotten it going in the psychiatry department yet, but they have around issues of particularly diabetes, hypertension, and so on and so forth, where the diabetic patients are helping each other manage their diabetes. There's no nurse, no doctor, no one else involved in doing it. So, you got to kind of think outside the box. You have had your hand up many times.
First off, an appreciation. San Capital, University of San Diego, a doctoral student. The synthesis, I mean, even if you said that you've been here as a group for a short time, synthesis was wonderful. Wonderful. I mean, literally, you hit topics that's, scratches every itch I almost have. That is amazing. So whether it's leadership jazz into the artificial intelligence, into the contextual nature, into the followership. So first off, I'm very glad to see the leadership systems approach being applied, and not just at a theoretical level, but somewhere of now what does this mean? So really excited to see that. On the PD discussion with regards to the suicide, one of our colleagues, Carmeline Rivera, he's actually another doctoral student, but he's actually at a conference in Chicago today. He was here yesterday, but he had to fly for the other conference. And he actually does that work for the San Diego PD, where they have a very strong peer support group, in a sense, the theory of how do you unload those rocks in the backpack that you carry over 20 years. So there's a peer component that may be beneficial, and if you're interested, I can help you connect. But and lastly, on artificial intelligence on the team, is there a conversation about a technologist being on the team? Because along with artificial intelligence, you're going to have to bring in somebody that helps interpret part of it, at least, as you focus on more of the human dynamics. So typically, technology is seen as a support function. I'm not sure how that transition is going into being more of an active component on these teams. So question back.
Yeah, we do have we're involved in prime initiatives, which people in the health.
You're right.
Yeah, you're right. And you are right. And we do have a technologist that we just hired to be on our team along with us.
Thank you. Great presentation. And Susanna, when you were talking about how it used to be, and that the nurse was kind of overlooked as the person who spent the most time with the patient, had the most patient expertise. And what I started thinking about when you were talking about teams being formed, who's going to be leading the teams and whether it's still going to be kind of mapping onto the positional hierarchy of the institution. And it led me to this other thought about part of leadership training needing to include looking at implicit biases and how they play out along lines of sex and race, both in terms of how people in the system are unleashed, but also how health professionals are trained to understand structural inequalities as a lens for helping to understand what the obstacles are to patient health. So I'm kind of wondering how that gets woven into leadership training.
So all I'm going to add to that, you're absolutely right. What we've done is we're incorporating a lot more interprofessional education teams. And when we do active, what are military and medical field practicum, we use advanced practice nurses in addition to physicians. Who should lead the team? Whoever is the most knowledgeable, depending on the task. So we're trying to evolve it in that way. Clearly, there are the assumptions and biases of medicine versus nursing and the like, but we hope we're moving in that direction. I just want to, excellent point you made.
So earlier I was talking about the domains of psychological safety, and I talked about open conversation, willingness to help, attitude towards risk and failure. And the fourth is what Deborah was just bringing back, is inclusion and diversity. So how good is the team at including different types of voices? And diversity can be different kinds. It could be a machine, an artificial intelligence. It could be a technologist. It could be someone of a different gender. It could be lots of different ways of looking at diversity. To build on Neil's point and contrast a little bit, it may not just be the person that's most knowledgeable. I think that's going to be changing more and more, because probably the machine will be the most knowledgeable, but may not be in a leadership position. It might be the person that's most skillful at leading the team that should be the team leader, not necessarily the knowledge. I think knowledge is kind of like the past we thought the doctor had a knowledge, therefore he or she should lead the team. But I think it's going to change more. It's like, who has the right skill set to lead the team in that moment?
I love this panel too, and I sort of think the spontaneous. Well, I am biased. I can tell you more about that. Very biased. But yeah, and Michael was my student, and Mario's my close friend. So, and Neil, we're going to be close friends. Yeah. I just wanted to let you know that there was a news flash when I was filming this that said the Surgeon General of California decided that all children in California have to have trauma assessment. What a phenomenal thing that is. What leadership that is. Everybody, right. Not just the people that you think might be in trouble, but us ordinary people who are skilled at hiding it, right? Yeah. And the other thing is that I've traditionally had a doctor from the AMA come and be in residence at the Academy of Leadership. And that might be something those that have leadership centers, you might think about hosting an AMA, fellow who would come and do leadership. Or MP. Right, or MP. Well, I don't know if nurses do, but I mean, nursing has really gotten the leadership bug. I mean, there are endowed chairs of nursing now in leadership, and it's just phenomenal. Of course, the Army is a major contributor to our thinking about leadership.
The head of our health system is a nurse. CEO is
Yep.
a nurse.
Yep.
So yes.
Right.
And the head of our public health department is a nurse practitioner.
Huh,
And,
yeah.
The head of our homeless division is a social worker. they had all the doctors in those positions, and they're just really, other specialties and just taken over, which is wonderful.
Yep, that's fantastic. Well, I'm really excited about the idea that the healthcare professions will have a community here at ILA. I'm just really excited about that because I've seen these panels grow from, a few people to more and more people are interested in presenters and so forth. So I think, and I'm a patient, by the way. I'm seeing it from the other point of view. I have a pretty serious kind of cancer. Susanna helps me. Mario did a ton of research for me sitting in his car between his patients. Deborah comes and helps me weeks or two, and she's one of the busiest people I know, to be in my home to help me, with cooking or, just staying lighter, So I think, mobilizing the leadership aspect of healthcare is really important because I know what it's like to enter the medical system, and it's not fun. It's not fun. And fortunately, I have some of the very best doctors because Susanna researched them. She saved me from a surgeon who wanted to cut out my liver when our second opinion said, you do that and you're going to die on the table, So you have to really have advocates, who have leadership and knowledge and experience. So I really appreciate that. Thank you all. And try spontaneous again.
I really enjoyed this panel, and I think I echo the comments made earlier in terms of how this is actually a good example of the application of the body of knowledge and practice that convenes at ILA in terms of leadership. I think as Mario was alluding earlier, in the Toronto area, I have been for almost now 22, 23 years, doing a lot of volunteer work in suicide prevention and mental health, mostly with refugees and newcomer communities. And I think my question to the panel is in what ways I think the notion of Kirkpatrick, for example, moving from a concept of just training to learning effectiveness, paying attention to coaching and mentoring and so on, make absolute sense in terms of the work that you're doing. To what extent, when we have culture as in the C capital, people coming from different linguistic and cultural backgrounds showing up at the ER or showing up at the hospital, in what ways is the navigation of this challenge integrated in the formation and leadership of doctors and health professionals?
Thank you. That's a terrific question. Two reactions briefly. One is, it's interesting, you were using two words that we distinguish between training and education. One of my colleagues puts it beautifully, John McManigal, who's a critical care physician. Training is prepared for the known. Education is preparing for the unknown. And we have to do both in that way. The other part that you have is a more practical one, which is interesting. One of the places where ILA obviously deals with from the academic to the practical. But here's something else that we've been exploring with annual summits we're using with representatives from medical schools around the country, around the United States, interested in these topics. The fact is, there's only one way to ensure that it becomes part of the curriculum of all med schools. And that is, we have to get, in our case, the LCME and the AMC to require it as part of certification and testing. So we're moving towards how to best do that without seeming too too oppressive and the like, but to get frankly, to use our best angels of Machiavellianism, if you will, to try to get them to understand they need to make this a required part of middle education is where we're moving. How can we do that? Well, actually, politically, one can do it by appealing to, and we're trying to engage those individuals who actually write the accreditation values. That's what we're doing right now. But I'd love to hear more ideas from the leadership group.
Wow, another domain that leaders have to deal with, politics. Okay, we have to end for today. Thank you all for coming. And Shelley has
just basically, we're with Shelley and actually in Dr. Sorensen's ideas, several of us are trying to find interest in putting together a healthcare leadership community. Apparently, we're required to have a certain number of signatures to exist. Shelley Wilsey has a list. If any of you interested in just supporting this idea, the cost today is $0. Tomorrow, I don't know what it will cost you. But seriously, if you would mind signing up, this is to let ILA Central know that there really is an interest in us developing to share ideas, platforms, perhaps surveys, perhaps political support, ideas around the country.
Okay, thank you, everybody.